Hi everybody, good afternoon. I'm delighted to be here today talking to you about neuropsychology and FND, and thanks very much to Eamon for inviting me here to speak. My initial reaction was, oh brilliant, I'm going to talk about neuropsychology and FND, and my very quick second reaction was, oh no, what on earth am I going to talk about? It's such a broad topic. So I started thinking a bit about the work I've done with people with FND over the last 10 years, and I thought, well, why don't I just talk about that a little bit? And I hope by doing so to demonstrate what I see as very significant progress in how everything is developing in Ireland for FND. So I really want to pass on that message, and hopefully will illustrate it through my talk today. So I'm going to, I just want to mention a lot of what I have gathered over the years is through the direct work from patients, which has been invaluable. I'm going to touch on what looks like quite a lot now, so I might start having to talk very quickly, but I really want to talk a bit more about the role of neuropsychology and FND. This is another thing that's come up time and time again today, the importance of education and training. The personal bugbear I have, which is the topic of stress and FND, the importance of support networks, and then I'm just going to mention towards the end some notable milestones and a little bit of what I would like to see happening maybe within psychology going forward. So setting the scene in a kind of reeling in the years style, I'm going to bring you back to 2014, which is when I started my current job in Beaumont Hospital. Top of the charts was this song that I have no recollection of, and these are some of the big stories happening that year. So I don't know if anyone remembers the Ice Bucket Challenge and some of the other. It makes me feel old when there's a reeling in the years episode about something that you think is only really recent, kind of. So this is 2014. In terms of setting the scene, in terms of where I work in Beaumont Hospital in the Neuropsychology service, and this service has three main strands to it. So we have the National Epilepsy Surgery Programme, we have Neurosurgery and Neurology, and because of as part of the National Epilepsy Surgery Programme, we have an epilepsy monitoring unit in Beaumont, and this is where patients are referred from all around the country for investigations and diagnosis of seizure disorders. And because of that, quite a lot of the functional presentations I work with are functional seizures. But just to illustrate too, FND patients come our way through neurosurgery, not as much, but a lot through neurology as well. And I suppose what I wanted to highlight as well is that unfortunately FND is only one part of the work that we cover. So I have a remit across all three of these services. So FND, certainly though in my experience, we are getting more and more referrals as the years have gone on. So this is something that is really important that we really need to keep addressing. So. Moving on a little bit more specifically now to the role of neuropsychology in FND, and I'm going to talk about one of the first patients I worked with. And this lady was diagnosed with functional movement disorder or functional weakness by neurology about 2 years previously, and then discharged from neurology and referred to neuropsychology, where she sat on our waiting list, unfortunately, for about 2 years, which wasn't unusual at the time. Of course, she deteriorated over time in that period, and by the time she came to me, she depended on a wheelchair for mobilising. She had significant pain and a complex psychosocial history. I gathered her history, I developed her formulation, and I started working therapeutically with her, primarily using a CBT model. And after 8 sessions, there was no improvement in her mobility, despite some subjective improvement in distress. And you're probably all sitting there going, well, of course, Sarah, what were you thinking? I actually thought my job was to get this lady up and walking purely by coming to neuropsychology, and which seems incredibly naive now, but that was actually where we were at, or certainly where I was at in 2014. And so the early learning was how essential NDT input is, and that has obviously stayed with me for every patient I've met subsequently. So what was happening here was a bottleneck of patients with FND who were being diagnosed, and we're lucky to get a diagnosis, but then we're being siphoned off to neuropsychology. Our service couldn't cope with the number, and so people ended up being on a waiting list for a long time. And of course we see this deterioration in function and a delay in receiving the appropriate care. And a thing that has really struck me over the years is how important triage is. It's such a crucial part of how we work with FND. This lady needed physiotherapy, social work, and possibly pain management, I hope subsequently she got access to some of these. I also wondered, well, did she actually need neuropsychology? You know, what were those 8 sessions about? And I suppose, initial answer to that is maybe she did and maybe she didn't. So I'm going to explore that a little bit further now. So as neuropsychologists, we're interested in the brain function and dysfunction and how these interact with psychological function, and by that we mean emotional behaviour and cognition. So we're well placed to work with patients with a brain-related condition such as FND. And I'm going to show you 2 typical types of referrals to our service, so a patient with epilepsy and a patient with functional seizures. For the patient with epilepsy, I'd be thinking, well, my role here might be to provide intervention to help the patient manage adaptive challenges of living with a really difficult condition like epilepsy, to help with improving quality of life, maybe to assess cognition and provide some intervention, and possibly to treat comorbid anxiety and low mood. When I meet my patient with functional seizures, I'm thinking, what's my possible role here? And we have exactly the same things that might be relevant. The key difference, though, is sometimes there is that expectation that my job is also to cure the seizures. And this places us in a very different position in terms of how we work compared to how we work with other neurological conditions. So neuropsychologists can work with a wide variety of neurological conditions, and we assess and treat the psychological aspects of the condition. And this is also true of FND, of course, but as I said, there can be an added expectation that input from neuropsychology may cure the condition or resolve the symptoms. And that's where I was in 2014 and probably for a while after. This, as we mentioned several times already today, is related to this earlier idea that FND is caused by psychological trauma. And one of the side effects of that is psychology being seen as core to treating everybody with FND. But as Aoife mentioned as well, there's a massive shift in 2013, which didn't really filter down into clinical practice for some time. I think it is still filtering down, to be honest with you. But trauma was removed as a required diagnostic criteria for FND. We know that many patients with FND don't have a clear or identifiable psychological stressor. But as we've spoken about already today, it's still highly relevant. So we're not discarding it at all, but we're broadening our perspective a bit here. So rather than having to have a link to psychological distress, we have expanded our understanding of FND, which is really helpful. But I suppose what I think then is, well, then if someone doesn't have a trauma history as such, does that mean there's no role for psychology in working with them? Because that was quite a simplistic kind of model before, I think, trauma and psychology, and that can be helpful. But it's not that simple, of course, because trauma isn't the only potentially relevant psychological factor in FND. So, for example, somebody may come to clinic and they have no trauma history at all, but they may have other relevant psychological factors that put them at risk for developing FND, and we've talked about this a bit earlier today, and these may be addressed through psychological intervention. We'll also have patients coming through the door who don't have any identifiable psychological vulnerability factors, but they may have psychological factors which are contributing to maintaining their symptoms, which we've heard spoken about a bit earlier today. And these can be really important targets for intervention by psychology. And also we may have patients with FND who have no psychological risk factors or maintaining factors, and you're thinking, well, do we have a role here? And yes, we do, because as I mentioned, it may be about providing psychological support to help manage their condition. It may be about improving functioning and quality of life. It may be about providing interventions for co-occurring difficulties, whether they're cognitive, mental health or emotional, as is our role in any neurological condition that we work with. So you may have noticed I haven't yet answered the question, can your psychological treatment cure FND? And one thing I would say next is, well, let's look at the literature and what does it tell us? And there is definitely, in the last 2 decades, a growing body of literature looking at psychological interventions in FND, and I'm not going to go into this in any detail, but there's plenty of meta-analyses and reviews. Slightly frustratingly, the conclusion is pretty much that some psychological interventions are effective for some FND patients in terms of symptom resolution. So by that I mean getting rid of the symptoms or getting complete relief from symptoms. And this may particularly be the case for functional seizures where psychotherapy is the treatment of choice. And a huge variety of psychological approaches are used, and with varying degrees of success. I think what's important is that other studies, while they may have shown no direct beneficial effect of psychological intervention on symptom resolution, there can be clear benefits for other secondary outcomes, such as psychosocial functioning, quality of life, and the phrase I like, bothersomeness of symptoms, so reducing bothersomeness. So can a neuropsychological intervention cure FND? Sometimes for some patients, plus or minus input from other members of the MDT. So there's no straightforward answer to this, unfortunately. I think it's really important that we're honest about it. Is there a role for neuropsychology in treating all patients with FND? Potentially. But the goal of the intervention or the expected treatment outcome may vary, and not all patients with FND require the same amount or type of neuropsychological input. And why is it important to be clear about this? And again, I'm probably stating the obvious in a lot of ways, but these are things that I've encountered many, many times over the last, actually 11 and a half years I'm in the job, but it didn't sound as catchy as 10 years of clinical experience. So it's really important to be clear because it's about managing expectations of treatment. So what I now do, and it reminds me very much what Miriam was speaking about, if a new patient comes to me, I say very clearly at the outset, the goal of our work together is to help minimise the impact of your FND on your functioning and to improve your quality of life or help you live your best life. Whereas when I started off working in FND, I thought I was meant to say, we can cure this. And it's a totally different position to be in. So by shifting this emphasis, we do lots of things, all of which I think are beneficial. An immediate thing is reducing the pressure for both the clinician and the patient. And this is in a context where there's so many unknowns about FND and it's so difficult to give definites. But I think what we need to do is just say that. There's a lot of things we don't know, rather than kind of fudging it a bit and saying, well, there's loads of stuff we don't know about FND, and let's just, have that out there on the table. And, an intervention from neuropsychology may lead to a complete resolution of symptoms, but this isn't the goal of treatment, and it's certainly not the only measure of treatment success, and that's, I think, really, really important. As a slight aside, certainly with my work with functional seizures, there is for many patients an issue where fear of having another seizure becomes sufficient to maintain the problem, very much like with panic disorder. And if we can break that cycle in any way, we're winning, and it can be a really key point of intervention with functional seizures. So what we're trying to do is help the patient shift from, I really, really hope I don't have another seizure, to, it would be great if I don't have another seizure, but I know I will manage it if I do. And this is a totally different headspace to be in. I think deactivates the threat response and in a way kind of comes at it from the side in terms of helping with outcomes. I don't want for 1 minute to suggest it's about saying to someone with functional seizures, just don't worry about it and you'll be fine. That's not it at all. It's about putting in place a management plan to help them feel more confident when they have seizures, and that includes looking at family and systems and how everyone responds. So as I said, I really don't want anyone to think I'm saying, oh, you just don't worry about it, you're fine, because that's actually not it at all. So the other reason why it's really important for us to understand our role as neuropsychologists is to facilitate effective triage, and especially when resources are limited, we really need to be aware of the best way that we can help in the most efficient way. That also means knowing what we can't do. So that lady I spoke to you about, my first patient, I'm sure hopefully it wasn't an awful experience for her, but in terms of what she needed, it wasn't of value to her. And I could have been seeing another patient who would have benefited much more from that time. So while we know now that the clear diagnosis of FND is absolutely crucial, I've really begun to appreciate the importance of triage of patients with FND, getting the right patient to the right place at the right time with the right healthcare provider. And this ideally will lead to a targeted, individualised MTT intervention. I know this isn't happening in a widespread sense, but I think it's really important to know what we're aiming for when we're working with FND. So I'm going to move on a little bit, 15 minutes, okay. And talk a little bit more about education and training, and maybe more specifically how it relates to neuropsychology. So in 2014, when I started work in Beaumont, at that point I had done 11 years of postgraduate training and study in psychology. And it was only in that 11th year that I heard about FND or had any input into it whatsoever. And so, training and education around FND and psychology was a bit of a wasteland. And so I think as we've heard today, it wasn't just neuropsychology. So Roisin, who spoke to us earlier from physiotherapy, led out on a survey in 2023 looking at the attitudes and perceptions of Irish healthcare professionals in terms of FND. And one of the areas we were interested in was education and training. And you won't be surprised to hear that the majority of respondents felt they hadn't received adequate training. But on a really positive note, there was a real appetite for learning and a real appetite to want to know more, to want to be able to provide help. And I found that really, really heartening. So while it's tough in terms of the lack of education, the key element for me is that there's a willingness and a desire there to learn more. There was also, I suppose, it's not just about improving our knowledge, but as Caoimhe very nicely spoke about, if we can improve our education training and improve our knowledge about FND, we can help reduce stigma. And I won't dwell on this because Caoimhe has talked about it very well. But just in terms of that idea that if we can get in there early and help clinicians understand and feel prepared to work with this condition, that goes a long way in terms of helping with stigma. And as I say, I really do think things are improving. So at the moment I give FND specific input on 5 postgraduate psychology courses nationally, and 3 of these are clinical trainee programs. And when I started doing these lectures, maybe 7 or 8 years ago, I'd always start by saying to the class, has anyone heard of FND? And I'd be met with a wall of blank faces, and that was my starting point. So about 3 weeks ago, I was in Trinity lecturing the 3rd year trainees on the clinical programme, and I started out with my question, and everyone in the class nodded their head and said, yes, I've heard of FND, and at least half said, I have worked with FND, which was absolutely fantastic. There's usually at least one person in the class doing research on FND, which we are seeing more and more. And for me, the highlight was when I said, does anyone know the best treatment for FND? And someone actually said MDT, and I nearly lost my mind. It's like, so without, these things are really important. I think maybe it was Aoife who mentioned it can be very hard to see progress. It really can, and it can be very, very disheartening. But when I step back and look back on the last 11.5 years, I definitely see positive change happening, and we need to keep going with that. Moving on to a slightly separate but related issue is stress. So I'm not going to ask for a show of hands, but I'm pretty sure that most people with FND at some point have that the word stress has come up in conversation somewhere along the line. So it's often cited as a risk factor for developing FND. But I suppose where I get really stuck and still haven't resolved is, what do we mean by stress? Is stress the same as trauma? Is it the same as threat, like a threat response? Is it pressure on your system? Are we talking about a psychological process? And most importantly, are we all talking about the same thing? And I think the answer is no. And for me, how we conceptualize stress and FND is a bit like this fella here. It's crude and like thumping things with a big club. And to be honest with you, I think it's also a bit lazy, and I'm just as guilty as that in terms of really sitting and trying to figure out what is the literature saying, what do we mean when we talk about stress? We tend to just say it and as a kind of comment, but I don't think that's good enough. And so there's a lack of consistency in terms of what clinicians mean about stress. There's a lack of consistency in how the concept is discussed with patients with FND, but it remains a very common part of explaining the diagnosis. So very often patients will come to me after receiving their diagnosis and say, I've been told it may be linked to stress. And it's often inferred still that stress in this context is psychological. And in my experience, what patients hear is stress you haven't managed effectively, or these symptoms you have developed because you aren't coping with the stress in your life, which is just horrendous. And no one intends to give that message, but because of how we think about stress, and we use it in common parlance all the time, these are some of the associations we have with it. And what happens is that patients then might feel it's their fault they developed their symptoms, or that if they just coped better, they wouldn't be experiencing these symptoms. And it can lead to quite profound feelings of shame and guilt, which again becomes a target for intervention when we're working with FND. It also incorrectly places the responsibility for recovery solely on the patient, and that's completely unfair. So we can do better, and I don't have a solution to this, but I just wanted to highlight today that I think how we conceptualize and talk about stress in FND is very crude, and I'm not sure how helpful it is. We use the biopsychosocial framework, and I'm not saying this is the best solution, but it can be helpful. So we talk about, as was mentioned earlier, biological, psychological and social factors that may be relevant in someone developing and continuing to experience FND. So we frame stress not just as psychological stress, but it may be biological stress, social, and it's about the fact that any of these are in combination can overload the system, and this can lead to dysregulation or breakdown in communication between key networks in the brain that are important for how we move, feel and think. And I'm not saying this is a solution to how we present the idea of stress in FND, but it's something I do and have been doing, and it's fairly acceptable usually for most people, but not always. So it's a work in progress and just something for us to think about. But it helps us move away from this oversimplistic conceptualization of stress as a purely psychological phenomenon. It helps us explain why MDT input is the optimum treatment model for FND. And it also helps really clarify for patients that they require professional input for treating their FND, and it's not simply a matter of coping better with stress. Another thing that has been very important to me in the last 11.5 years is the peer support I've got from colleagues. So I can't even remember the year we did this, but a few of us got together maybe 8 years ago and established a peer group for neuropsychologists based in acute hospitals working with FND, and it's been really invaluable for me. It serves multiple purposes: discussion about services, case discussions, what's worked, sharing resources, updates, space to acknowledge the challenges of working with FND, and a lot of that is ranting about services and all of that, and a non-judgmental space, which is also so important in peer work with patients, but also for clinicians, a source of support, reassurance and learning, which can really help reduce the clinicians' feelings of helplessness and frustration, which hopefully has a beneficial knock-on effect to every interaction we have with patients with FND. So it has been really helpful, and I think one of our most recent additions to the group works in a community neuro rehab team in the south of the country. So I see now going forward this group also may help us really improve our networking and spreading from acute settings out to community. So I'm heading towards the end. I just wanted to mention a couple of milestones in the last 11 years that have already been discussed today. But I suppose up until maybe 3 years ago, my impression of services for FND, both locally in Beaumont and nationally, was that there were lots of really good people rowing very, very hard, but not all rowing in the same direction at the same time. And we weren't getting very far, despite a willingness, despite a genuine want to help people. One of the big changes has been the establishment of FND Ireland in 2023, and again, the absolutely amazing work Eamon and colleagues have been doing, advocacy and support, peer support, and this whole patient partnership approach, which is absolutely vital. On the ground, what I have seen for patients is that this completely validates their experience. It kind of, puts things on a map in a way. There's a sense of belonging, and there's a sense that this is a real condition that really needs attention as much as any other neurological condition. And I think it's been, as well as kind of coordinating and galvanizing also, it's just been such a valuable step forward for us. There's a couple of important publications in the UK in the last couple of years. One was the NNAG's Optimal Clinical Pathway for Adults with FND, the NHS Scotland one, and for neuropsychology in particular, a briefing paper from the BPS about working with FND and best practice. All of these have been really helpful, and we're getting much more clarity. While we don't have the ideal services, there are definitely very clear models out there of what we should be aiming for, and that's great. Of course, then the fantastic news we heard that there was going to be a specialised MDT clinic in James's Hospital, and I really do feel in the last 2 or 3 years that we're beginning to row in the same direction, which is fantastic. But I also acknowledge there is still quite a long way to go. Just a small note of caution, I had a patient in clinic recently who was coming to me as part of the epilepsy surgery programme. He was coming up from a regional hospital in the south of the country, and he also had functional motor symptoms, and I just asked him, are you having any input from that? And he said, no, but it's okay because I'm going to the clinic in James's Hospital. And again, I suppose we have to be really careful, as we've talked about already. One MDT clinic, while absolutely brilliant, and it's going to be a flagship and a model for how we need to go forward, that doesn't mean we can sit back and be complacent. It doesn't let other services off the hook. So it's easy to say, oh, you can go to James's, which is I'm saying absolutely brilliant, but I worry sometimes it'll give people a bit of a get out of jail card, and by that I mean health professionals, in terms of, well, now we have this service, isn't that great, so I don't have anything else to do here. And I think, just wanted to name that. We know that specialist MDT clinics are crucial, but they're also a part of a whole system approach to care for FND. So on their own, while they'll do absolutely amazing work, it has to be linked up with services within the community. There has to be a continuum of care. What does this mean for neuropsychology? Well, we need more neuropsychologists, first of all. There aren't enough. But the other thing I wanted to talk about is that people in Ireland working as practitioners in neuropsychology have already completed their doctoral training in either clinical or counselling psychology. And as part of that training, we have acquired competencies in assessment, formulation and intervention. And these are exactly the skills that are required to work with FND. So when I'm lecturing to doctoral trainees about FND, this is one of the slides I use, because they often say, well, this isn't relevant to me, I'm not going to work in neuropsychology. And I'm like, but you're working in clinical psychology and you can really help here. So I just point out that they already have the skills. What they don't have, of course, is probably the experience, the sufficient education, there's an anxiety around it, and that's a role for us maybe as neuropsychologists to help support and promote and really encourage all these really skilled psychologists to jump in the boat with us. So just to conclude, as I said, I've seen really positive developments in the last number of years across all of these different areas, not just in models of service or service development, but in advocacy, how we understand FND, etc. But there's lots more to be done, of course. Neuropsychology/psychology has an important role to play in all of the above, in addition to direct clinical care. And just on that note about us expanding out and supporting colleagues in psychology who may not have specialised in neuropsychology, this year the keynote at the Psychological Society of Ireland's National Conference is on FND, which has been arranged by my great colleague Sarah Casey. And again, it's us trying to get the message out that this is something we can help with. It doesn't have to be just a neuropsychologist, a wish list. If I was here in 10 years, I would like to see further clarity around subtypes of FND and what psychological interventions work best for which patients, so clarifying our role. As I mentioned, this more refinement of how we talk about stress in FND. So many patients I've had have pain, and it can be a really big barrier. And I don't think it's realistic to think pain management would necessarily be part of an MDT, but I think access to pain management would ideally be extremely helpful. I'd love us as well to develop our understanding of issues such as neurodiversity, gender, and other issues related to cultural diversity. I like this idea that there's a big literature on the nocebo effect in healthcare, which is, how psychological processes can directly influence physical outcomes, and I suppose that's where I want to end up with today. We've talked a lot about the mind-body gap and how it's relevant to FND, but when someone is diagnosed with any health condition, a physical health condition, they become a patient, but they are also still a human being. So they also still have got psychological and things impacting on them as well as social and cultural. And so a purely medical model isn't going to work. Likewise, if someone is diagnosed with a mental health condition, they don't leave their physical body at the door. They still have a physical body which is relevant, and they also are not impervious to social and cultural factors. For me, FND acts as an absolutely fantastic model in really making us sit up and I suppose highlighting that we need to have a better understanding of mind-body work, not just for FND, but for every single health condition, whether it's physical or mental health. And I think it's a positive note to end on. I think we've a lot more to learn about FND, but also a lot more to learn from FND. Thanks, everyone.